Hello everybody, I am Dr. Rakesh Pathak from Nepal, and first of all I would like to thanks to your organizing committee of this conference, that is 5th International Breast Pathology and Cancer Diagnosis, which is going to be held on 4th and 5th April 2018, and I got opportunity to present my paper in your this very large forum. Regarding my introduction, I am Dr. Rakesh Pathak, and I am currently a pathologist and working as an assistant professor in the Nepal Medical College and junior consultant pathologist at Bhaktapur Cancer Hospital since around 6.5 years. And beside these two hospitals, also I am involved in other neuro hospital that is called as Dirgai Guru Hospital, which is in the Kathmandu. And my topic is histopathological evaluation of carcinoma of breast, and I would like to get permission of you to start my topic. And regarding the introduction, breast cancer, as you know, is the most frequently cancer among women in the developing as well as developed country and become the major public health problem worldwide, with nearly 1.77 million newly diagnosed cases in 2012, representative 25% of all female cancer. Among Nepalese women, breast cancer is the second most common type of cancer, accounting 6% of total cancer in Nepal. In Nepal, more than one quarter of the breast cancer is diagnosed in young female, and many being diagnosed at an advanced stage, with tumors showing more aggressive biological behavior. The familial history of breast cancer and mutation of tumor suppressor gene like BRCA1 and BRCA2 and P53 increases risks of breast cancer. Alcohol consumption, high dietary fat intake, obesity, overweight, diabetic mellitus, and physical inactivity has induced breast cancer incidence. In context to Nepal, breast cancer is commonly diagnosed in female with late menarche, early pregnancy, long lactation period, less breastfeeding, change in lifestyle and dietary habit, family history of breast cancer, and contraceptive user. With rapid increase in breast cancer, tools used for early cancer diagnosis and management in Nepal include breast self-examination, imaging, surgery, chemotherapy, radiation therapy, palliative care, and cancer education. The surgical removal of breast followed by chemotherapy and radiotherapy is the common practice used in the disease treatment. The histopathological factor of breast tumor, like tumor size, lymph node status, histological type, histological grade, presence or absence of hormone receptor, and age of the patient, play a crucial role on chemotherapy and radiation therapy. So the study aims to assess the clinical profile of the patient with breast carcinoma as well as macroscopic and microscopic feature of modified radical mastectomy specimens. Now coming to the materials and the method, the present prospective cross-sectional study was carried out at Department of Pathology, Bhaktapur Cancer Hospital. Total number of 112 cases that underwent modified radical mastectomy (MRM) in Department of Surgical Oncology, Bhaktapur Cancer Hospital between January 2014 to September 2015 were included in this study. Modified radical mastectomy specimen with no residual tumor, patient having previous history of radiotherapy or neoadjuvant therapy were excluded from this study. The clinical details like age, sex, laterality, mode of tumor presentation, skin and nipple level changes were all assessed. Macroscopic examination provided information regarding size, number, and tumor location in mastectomy specimen. Histological type, stage, grade, lymphovascular invasion, and lymph node involvement were evaluated by microscopic examination of H&E stain tissue section. Tumor grading and staging were done according to the Nottingham modification of Scarf, Bloom, and Richardson, we call as SBR system. SBR grading system and TNM staging, where T describe the tumor size, N describe the nodular involvement, and M describe the distant metastasis. The tumors were given scores according to Nottingham Prognostic Index, which we call as NPI scoring system. Nottingham modified grading system comprise, as you know, I think tubule formation, pleomorphism, mitotic count, these three things. Like for example, score 1, score 2, and score 3. And in nuclear pleomorphism also score 1, 2, 3. Mitotic count also score 1, 2, 3. And all the observed data were tabulated in MS Excel and statically analyzed using IBM SPSS statistics software version 16. So coming to my result in these cases, the study comprised of total of 112 breast cancer patient who undergone modified radical mastectomy, of which out of 112, 109, that is 97.3% were female, and only 3 number of cases, that is 2.7%, were male. The age of the female patient ranges from 27 to 87 years of age, with a mean age of 49.29 years. Majority of female patients were within age group 41 to 60 years of the age. The age for male breast cancer patient was between 59 and 84 years, with a mean age of 70.67 years. As I have already described, there are only 3 patients out of 112 we got the this study. In our study, invasive ductal carcinoma was the most commonly observed histological type of breast cancer with 84 cases. Carcinoma with medullary carcinoma was the second most observed type, followed by lobular, papillary, apocrine, mucinous, and not specified mixed type. So in my study, 84 number of cases, that means around 75% is invasive ductal carcinoma, followed by carcinoma with medullary feature, only 6 cases, that is 5.4%, followed by lobular carcinoma, only 4 cases, invasive papillary carcinoma 3, and less mixed NST and micropapillary carcinoma is only 2 cases. So total 100% of cases, that is 112 number of cases. In the present study, we found 14 cases were of grade 1, 86 cases were of grade 2, and 12 cases were of grade 3. So my result suggests that grade 2 type of tumor, that is around 76.79%, followed by grade 1 12.50%, and followed by grade 3, that is only 10%. In the present study, we found maximum 75 cases were T2 stage, that is the tumor size is 2.5 to 5 centimeter, and frequency of the tumor were T3, T1, and T4 respectively. And another finding in my study, that on axillary lymph node involvement, in this study we observed majority of the cases were N3 stage involving more than 10 lymph node, followed by N0, N2, and N1. So this is the main result of my study, that maximum patient were diagnosed as grade 2 and maximum patient are diagnosed as N3 in Nepal. So I think this data is slightly different from developed country to developing country. So now coming on discussion part, breast cancer is the top cancer in female population worldwide, and incidence has increased at the rate of 3 to 4% in developing country and often gets diagnosed at late stage. According to a study conducted in central Nepal, breast cancer has high prevalence among reproductive cancer, and suspectable age group was 40 to 50 years of age, female. In this study also we found female age between 41 to 60 years, had higher prevalence of breast cancer as compared to other age group. There are different study done in different paper which is almost equal, almost similar to my study regarding the age of the patient. In male patient also we observe invasive ductal carcinoma was the most common type of breast cancer, followed by invasive papillary. In this study we found medullary carcinoma was the second common histological type, although first common type is the invasive ductal carcinoma. I have already mentioned around 75%, that is 84 cases out of 112 cases, and second is medullary carcinoma, that I already described, only 6 cases, that is 5.4%. Histological grading and are based on Nottingham modification of the scarf bloom and Richardson grading system. The extent of tubule formation, nuclear size and pleomorphism and mitotic rate are the parameter measured. Each of the 3 elements was assigned with a score 1 to 3 and the final grade was identified from the sum of each individual scores. Like grade 1 is scored 3 to 5, moderately well differentiated, moderately differentiated grade 2, that is score 6 to 7, and poorly differentiated, that is grade 3, that is score 8 to 9. In the present study, we found a majority of the tumor were moderately differentiated grade 2, that I have already discussed. And another is according to the AJCC, American Joint Cancer Committee. We always followed in our report, AJCC, in my report, in both cancer hospital and medical college. According to the AJCC TNM staging criteria, the tumor size varies from 1 to 9 centimeter, with majority 67% of tumor belongs to T2, that is 2 to 5 centimeter, followed by T3, that is more than 5 centimeter, followed by T1, that is less than 2 centimeter, and T4, that is tumor growing to chest wall or skin. Our study observed 47.72% cases with T2 that stage that correlate with our result. Another is, in this study, highest frequency of tumor belongs to N3. As I have already mentioned, in country like our developing country, in Nepal, maximum cases we diagnosed as our patient patient came to hospital at N3 stage. In my study also, N3 stage is more common, followed by N2 and followed by N1, N2 and N3. In addition, we found 70% cases had lymphovascular invasion and 49 cases had perineural invasion. There are different study by Songit and reported MRM cases that maximum percentage of breast carcinoma had lymphovascular invasion, similar to my result. So as a conclusion, the present study has provided the information about the histopathological aspect of breast cancer patient diagnosed at Bhaktapur Cancer Hospital, Bhaktapur. Invasive ductal carcinoma, NST, no special type, was the most common histological type breast cancer. Majority of patients were diagnosed with tumor at T2 and N3, that maximum at grade 2. So our study puts prognostic significance of histopathological information in treatment planning and strategies. Thank you very much. Also, lastly, I would like to acknowledge all the staffs of Department of Pathology of Bhaktapur Cancer Hospital who have helped especially me for this research work. And lastly, I would like to thank our main coordinator of this conference. Actually, I haven't met her till now, just we discussed or we talked in email. Madam, I think Catherine Chage, who repeatedly pressure me to present this paper in your international forum, and I am very happy to present this paper in this international forum. Hope we'll meet any day with other new paper. And actually this paper is every day. I am working in my hospital every day after 3 o'clock, 3 to 6, 7 o'clock I work in this cancer hospital after Nepal Medical College, and every day I am working on this histopathology and cytopathology. This is actually 2 years back story, but nowadays also I am every day I am reporting this MRM specimen. I think today's scenario is also not changed. I think this same type of scenario is also seen in nowadays also. Means maximum patient come with T2, N3, and maximum I will give the report nowadays also grade 2. So and common types of histological, that is invasive breast carcinoma, NOS, and followed by carcinoma with medullary feature. Once again, I am very happy to present this paper from my country. Hope you will accept this paper in this conference, and thank you very much, especially our madam and all this the committee member of this conference. Hope this conference will get a big success, and also hope next time I will come to you with you and present this paper in front of you. Thank you very much. Hope. Thank you.